Anesthesia coding. Anesthesia services are usually billed by a physician or a certified specialist whose sole purpose is administering and monitoring the anesthesia and its effect on the patient. The anesthesia provider or specialist is not typically performing the procedure in addition to the anesthesia. However, at times, the provider performing the procedure also administers the anesthetic agent. Anesthesia, which means a loss of sensation, is administered to patients to relieve pain brought on by any number of causes, including surgery. Anesthesia can be administered by a qualified professional through injection, inhalation, and agent instillation. It is important for the coder to determine who administered the anesthesia because reimbursement will vary depending on the provider. Modifiers are used to indicate whether an anesthesiologist or a CRNA delivered the anesthetic. There are types of anesthesia. Which alters patient's perception. It affects the whole body, causing a loss of consciousness. This type of anesthesia is typically administered by injection, inhalation, or instillation, or a combination of these techniques. Injection of an anesthetic agent involves the anesthetic being administered directly into the bloodstream. A venous access device is used, which allows the medication to circulate through the bloodstream. Inhalation of anesthetic agents requires the use of the circulatory and respiratory systems to efficiently move the agent through the body. Typically, a vaporizer is used to administer this type of anesthesia. Instillation of an anesthetic agent is used if there are problems administering the agent by injection or inhalation. During instillation, the anesthetic agent is introduced into the cavity of the body that has a mucous membrane, such as the rectum. The mucous membrane allows the anesthetic agent to be absorbed into the circulatory system and then transported to the central nervous system, thus anesthetizing the patient. This technique is not commonly used, but is necessary in cases where the patient is not cooperative or when other approaches have failed. Regional anesthesia, as the name suggests, anesthetize a particular area or region of the body. This is accomplished through nerve or field blocking. The anesthetic is injected along a major nerve track and thus interrupting the nerve conductivity in the regions of the body. This type of anesthesia also is referred to as a block anesthesia or conduction anesthesia. Common types of regional anesthesia include fire blocks, injection of an anesthetic agent into the arm below the elbow or the leg below the knee, epidural blocks, which is an injection of anesthetic agent into the epidural space above the dura mater, which contains the spinal nerves and the cerebrospinal fluid. This is most commonly performed in the lumbar area. Local anesthesia numbs a small area such as a finger or a toe and occurs when an anesthetic agent is applied topically to the skin or injected subcutaneously. Local anesthesia is used for dental procedures and brief surgical procedures. In the hospital setting, anesthesia codes are not reported because the anesthesia codes represent the professional services provided by the anesthesiologist or CRNA. Anesthesia codes are used to report the professional services of the provider who anesthetized the patient. If the hospital is billing for the professional services of the anesthesiology staff, the anesthesia codes are used. The coding and billing of anesthesia services vary significantly depending on the payer and the state in which the service is performed. Medicare requires the use of CPT anesthesia codes, whereas some third-party payers require the use of surgery codes to bill for anesthesia services. It is of the utmost importance that coders verify the coding requirements for the area in which they are reporting the services. The codes submitted for the same anesthesia service can differ depending on the payer. Referencing the anesthesia section of CPT, you will note that subsections are organized first by anatomic site and then by procedure. 4 subsections of anesthesia, however, do not follow this arrangement. They are anesthesia for radiological procedures, burn excisions or debridement, obstetrics, or for all other procedures. Locating the CPT codes for anesthesia procedures is not as complicated as locating other procedure codes. The main term to reference the index is anesthesia. The index is divided after that term by the type of procedure performed or the body site of the procedure. If you look through the anesthesia section of CPT, you will notice that the anesthesia codes are general or specific. For example, general code is 00500, anesthesia for all procedures on the esophagus. However, code 00906, anesthesia for vulvectomy, represents a very specific code. Anesthesia for radiological procedures are found in code range 01916 through 01936. Anesthesia for burn excisions or debridement, the code range is 01951 through 01953. As mentioned, the code anesthesia for obstetrics, the code range is 01958 through 01969, and for all other procedures, code range 01990 through 01999. After selecting correct CPT code, you need to select modifiers to further describe the case. There are numerous types of modifiers that are used with anesthesia codes. One common error is that coders may make is assigning modifier 47, anesthesia by surgeon. This modifier is to be used only by a surgeon who administered regional or general anesthesia. Modifier 47 is added to the procedure code for the service performed. This modifier is not used for anesthesia procedure codes 00100 through 01999. As mentioned earlier in the chapter that we've been studying, anesthesia services are performed by anesthesiologists and CRNAs. Medicare and some other payers require the use of the 2-digit alpha HCPCS modifiers. Use of the following HCPCS modifier level 2 modifiers with anesthesia codes to identify the exact nature of the service provided. AA, anesthesia services performed personally by anesthesiologist. AD, medical supervision by a physician. More than 4 concurrent anesthesia procedures. And this modifier is used only by the anesthesiologist. G8, monitored anesthesia care for deep, complex, complicated, or markedly invasive surgical procedures. And G9, monitored anesthesia care for a patient who has a history of severe cardiopulmonary condition. Calculating anesthesia charges. To calculate the reimbursement amount for professional anesthesia services, the following formula is commonly used by the third-party payers. That is, basic value plus time units plus modifying units equal total units. Then total units times conversion factor equal total reimbursement amount. To understand the formula, you must understand the elements in the formula and the development of these elements. As mentioned previously, the AMA and the ASA published supplemental codes and guidelines similar to those in CPT, as well as relative value guide. The RVG contains the basic value for each of the anesthesia services and additional codes that act as supplements to the regular CPT codes, along with narratives similar to those in the CPT book. Because anesthesiologists perform other services, the RVG contains CPT codes from the evaluation and management, medicine, and surgery sections of the CPT book. Each anesthesia code has a basic value attached to it. The basic value, base unit, or base unit value has two elements. The basic value is also referred to as the relative unit. The first element of the basic value reflects the usual services attached to anesthesia services. The usual services refer to services included or in or bundled into the anesthesia procedure code, which would include preoperative visits, intraoperative care, and postoperative visits. The second element of the value of the work associated with anesthesia services provided. Therefore, these two elements determine the basic value for the anesthesia code. So the first element of the basic value reflects the usual services attached to anesthesia services, and the second element is the value of the work associated with the anesthesia service provided. Therefore, we need to make sure that we understand the two elements determine the basic value for the anesthesia code. The second factor in the formula to calculating the charge for anesthesia services is time. Anesthesia time is defined as the actual time spent providing the anesthesia service. This is recorded in minutes and is converted to a time unit. Time unit is independently determined by payers and represents a defined time increment. Commonly, the increment is 15 minutes, but some carriers use 30-minute increments. When a 15-minute increment is used, one time unit would be reported for each 15 minutes. To determine the time to report, the time starts when the provider is in the personal attendance to prepare the patient for the induction of anesthesia, and the time ends when the provider is no longer in attendance and the patient may safely be sent to the post-surgery recovery area. The last factor in the formula is the modifying units. These are determined by a patient's physical condition and qualifying circumstances that affect the administration of anesthesia. All surgeries are not equal. Like people, circumstances for procedures differ. Sometimes conditions are usually or out of the ordinary or significantly influence the administration of anesthesia. These situations are known as qualifying circumstances. These are reported using codes 99100 through 99140. When these qualifying circumstances occur, an additional qualifying circumstances code is reported with the anesthesia service code. It should be noted that Medicare does not recognize the qualifying circumstance codes. These qualifying circumstance codes are never to be reported alone. And if you note in the CPT book in front of each of the codes, 99100, 99116, 99135, and 99140 is the add-on notation, or the plus sign. And this notation alerts the coder that these codes are used in addition to the code for the anesthesia service. The qualifying circumstances codes are located in the Medicare section of CPT, but are explained under qualifying circumstances in the guidelines of anesthesia section. These guidelines should be read and understood fully before you assign any of the codes. The physical status of the patient can also affect the modifying unit's value. Physical status modifiers are used to describe the patient's health status. The explanation of the physical status modifiers are found in the CPT book, in the anesthesia guidelines. It should be noted that Medicare does not recognize physical status modifiers. These modifiers are summarized in Table 4.2 of your work text. And when a patient is given a physical status modifier of P3, P4, or P5, the modifying units are increased. To determine the total units for the anesthesia service, you add the basic value, the time units, and the modifying units. The total reimbursement amount would be calculated by multiplying the total units by the conversion factor used in the geographical region in which the service was performed. Moderate conscious sedation, codes 99143 through 99150, show a form of anesthesia that causes controlled state of depressed consciousness, but the patient is able to respond to stimulation. So in summary, anesthesia services are reported according to payer guidelines. Physical status modifiers identify the physical condition of the patient, and HCPCS modifiers are used for Medicare and some third-party payers. Anesthesiologists bill services separately from the surgeon, and charges must mirror charges submitted by the surgeon. Needs to be the same diagnosis code and the same procedure code.